Short editor.
Thank you very much, dear Chairman and Chair Lady. I'm very honored here to share our experience on genetic diagnosis of metabolic liver diseases. So as we all know, it will be a very heterogeneous conditions that involve a few or several genetic conditions. And most of them are monogenic in another way that is more easy to approach them. So we can classify the inherited liver diseases in carbohydrate metabolisms, like the glycogen storage disease. The patient will have a big liver. They can have hypoglycemia or high lactate. Or the patients can be galactosemia or fructose disorder as well. If they take the fruit glucose sugars, they will have liver derangement, and some patients can present with acute liver failure or acute decompensations to the ward. Another groups can relate to the protein metabolism defects, two are tyrosinemia, and the other groups is the urea cycle enzyme defects. I think the diagnosis of these are not so difficult because they are all linked to some good, readily available biochemical tests, like the organic acids or the lactate tests as well, and the sugar chromatography that you can also detect large amount of fructose or galactose. The third group is the lipid disorders or storage conditions involved in the lysosomes disorders, like the Gaucher one, the Lehmann-Pick, and the gangliosidosis. These are more difficult to diagnose because of the low index of clinical suspicions. Patients usually present with multiple organ involvement, but they also have hepatomegaly. And the diagnosis sometimes more rely on enzyme tests or some special biochemical tests like the oligosaccharides. And these are not readily available in many routine laboratories. Usually have to send to overseas or some territory-wide regional laboratories for diagnosis. But of course, they can now all diagnose by genetic tools. The third group will be mucopolysaccharidosis or the porphyria 1. And another spectrum in the hepatic or hepatitis picture liver failure, another group will be the cholestasis, like the progressive familial intrahepatic cholestasis. We can have type 1, 2, and 3. So these type 1 and type 2 will associate with a normal gamma GT, but a cholestatic picture. So the gamma GT level should be in 2 digits. Bear in mind that the pediatric reference interval for gamma GT is higher than adult or older children. So in neonates or infants, their gamma GT normally can up to 100. So you must use the appropriate age-specific reference interval when you interpret the gamma GT level to have the clue for whether these patients have like a PFIC when you consider the gamma GT is inappropriately normal in the presence of cholestasis. So the last 3 will be some peroxisomal biogenesis disorder. Peroxisome is a suborganelle that should handle some rubbish or very long chain fatty acids in our body. So failure to remove these very long chain fatty acids will have storage problems. So these are more syndromal patterns, and they will have upper motor neuron as well as lower motor neuron syndrome. They have seizures, dysmorphisms, and also some spasticity as well, together with liver impairment or cholestasis. Ehrlich syndrome is also a multi-organ problem that can have heart deformity and also the hepatic dysplasia. So Wilson disease was the most common one among these one, and I will have more discussion on Wilson disease. It is a defective in copper excretions leading to copper overload. So the last 2 here are more common in Caucasian population rather than Asians. The alpha-1 antitrypsin and cystic fibrosis. Occasionally we may see 1 or 2 in a decade, but it is really very rare in the Asian population. So the incidence, you can see it is all all rare. In definition, less than 1 in 2,000 is classified as a rare disorders. But you bear in mind that these incidents are based on case finding data. So for rare diseases, they present atypically or typically, because our knowledge on these rare disease patients is not enough, are not broad enough. So actually their presentation, we do not know all of them. And so case finding is deemed to have underestimation in the incidence. So until we have a good diagnostic tool or even a population screening, newborn screening to pick up these conditions, these incidents are not truly reflecting whether they are actually so rare or whether we are misdiagnosing them or underdiagnosing them. So my major focus is on Wilson disease, and this is Dr. Wilson. He was first described Wilson disease in 1912. This is an autosomal recessive condition that involves the CNS, the cirrhosis of the liver, and is progressive and invariably fatal. But once the diagnosis is timely and that treatment is available and effective. But Wilson disease is a master of disguise. It's very difficult to diagnose when they present with a typical picture. And even typical presentations sometimes can be difficult as well. There are 3 major aspects: the liver, the CNS, and the psychiatric diseases. So they can present isolated hepatomegaly or splenomegaly with portal hypertension. They can have jaundice, acute liver failure, hepatitis, chronic active hepatitis, cirrhosis, or Combs negative hemolysis with acute liver renal failure complications. CNS-wise, they can have tremor, dystonia, bradykinesia, dysarthria, etc. And bear in mind that 20% of the Wilson disease patients can present with pure psychiatric illnesses, so schizophrenia, depressive, or mania. So it's actually, even the typical presentation so-called in the textbook, I think it's still difficult to properly diagnose them, and sometimes clinicians may just request a ceruloplasmin, etc. That was more readily available in the laboratory, but it's, as all we know, that it is not a good enough diagnostic marker for Wilson disease. On the other hand, for atypical presentation, there are still a lot. Like patient can have present with HCC. They can be endocrine problem like amenorrhea or recurrent abortions. Some will present a joint problems, osteoarthritis. Some will have painless legs movement syndromes, isolated tongue protrusion movement, benign epilepsy of childhood, stroke-like or status epilepticus, recurrent abdominal pain, renal problem like stones or nephrocalcinosis, hematuria. Distal renal tubular acidosis can also be one as the presentation of Wilson disease affecting the kidney. So you can appreciate that Wilson disease patient not necessarily present with a hepatic problem with a KF ring. They can present with isolated problems, and the diagnosis can take long to come to an effective treatment. So last year was the 25th anniversary of the gene discovery by the Sick Kids group. So they have the celebration with this clinical and translation perspective on Wilson disease. There will be a lot of chapters on it, and I think I recommend this book if you are interested in Wilson disease. So is it really rare? The classical incidence code in the literature is 1 in 30,000, but this was a data collected in the early 80s from the case, 3 case sets of data collected from the 60s to the 80s. So they are case finding. Again, it is underdiagnosis likely, and so luckily we have more updated data from various groups, and the incidence of prevalence we'll say is 1 in a few thousands nowadays. Japan groups have a lot of studies, and I think it's a pioneer, one of the good pioneers in studying Wilson disease. So you have the whole ceruloplasmin immunoassay screening the children. You have using the urine assays or the sandwich methods to do a lot of studies. And in our groups, we try to use the genetic methods that we screen the most common mutations to tell where the carrier rate among the 600 groups of Chinese adults. And we found that the carrier rate is actually quite high, it's 1 in 200 something. And because this is a most common allele in our populations, and accordingly is about 1/6 of it. So we estimate that all mutant allele frequencies for this ATP7 gene will be 1.4% in the general populations. And using a highly variable equilibrium, we calculate the prevalence for Wilson disease in Hong Kong should be around 1 in 5,400. So actually it's quite similar to other groups using more populational screening tools. And I'm very happy to see that in Japan there is a population screening implement before a very long time ago, and there is a very good action on these very treatable conditions, but if untreated, it will be fatal. So in this paper, it mentioned that there is actively screening children from 1 to 3 years old because that is difficult to use ceruloplasmin in neonates at that time. So the better time, if you're using ceruloplasmin as the marker, a taller age is better. So newborn screening is still the dream for Wilson disease patients groups and all the healthcare working on this disease, because we really want to pick them up at a territory-wide method. So there are still different publications coming up. Once a few years' time, trying to do ceruloplasmin on driver spot samples, because newborn screening now we are using driver spot. And this group also document that they have a retrospective review. They have 2 Wilson disease patients present later on, so they go back to the driver spot at the newborn period, found that it's 0.026 or 2.6 milligram per deciliter. It's still far below the newborn normal range, that is around 6.5 to greater than 60 milligram per deciliter. So this group say that if this is a genuine Wilson disease patient, they can still be picked up at newborn age with a very or almost undetectable ceruloplasmin, provided that the assay is sensitive enough, and ELISA is more a sensitive tool for this. So another group published in 2008 that they use a tryptase PETA analysis to digest the ceruloplasmin and then submit to the mass spectrometry. Then this technology is widely used in most newborn screening labs to detect those acylcarnitine amino acid disorders. So, but this is more laborious. It takes a day to handle the tryptase digestion analysis. And it's not a commercial kit, so maybe it's more difficult to have a widespread applications. So apart from ceruloplasmin, another group recently tried on detecting the ATP7B protein itself. And as you may know that ceruloplasmin is not the direct culprit of this disorder. Because ATP7B is the direct protein that needs to incorporate copper into ceruloplasmin. For ceruloplasmin without copper, they degrade rapidly in the bloodstream. So Wilson disease patients also have very low ceruloplasmin level. But ceruloplasmin itself is not sensitive enough. Maybe 10% of Wilson disease patients will have a normal ceruloplasmin level. On the other hand, detecting ATP7B protein on driver spot seems to be a solution for newborn screening. However, the range of concentration is very low, down to picomole rank per liter. For ceruloplasmin, it's micromole, and therefore you can appreciate this group, they use a immunoaffinity method to enrich the ATP7B method before they submit to the mass spectrometry analysis. And they are able to differentiate that Wilson disease patient, they test 13 subjects, and this is undetectable limit of ATP7B, whereas the normal control, but the N number is 12, still can differentiate the two. So, but this is just a test of concept, haven't been applied to a larger population, but would be a hope if that is really able. So in our experience as well, Wilson disease is still the most common condition as inherited liver conditions. We want to pick them up and diagnose them properly because the treatment is effective. And the classical diagnostic criteria are 2 out of 3 that has been using 2 decades ago. Is the CNS involvement and the presence of the caser pressure ring and a low detection, low ceruloplasmin level less than 0.2. However, we know that these diagnostic criteria is not sensitive enough. False diagnostic rates can up to 50%. First of all, we can challenge the case of pressure rings. It is okay when the patient presents with neurological or psychiatric symptoms. But if the patient presents with hepatic or asymptomatic, most of them do not have KF rings. And also, KF ring is not pathognomonic of Wilson disease. They can be seen in non-Wilsonian liver diseases like the copper primary biliary cirrhosis, some ketogenic or active chronic hepatitis. So presence of KF ring itself is not 100% specific for Wilson disease. So the common marker, biochemical marker is ceruloplasmin. And the conventional cutoff is about 0.20 gram per liter or 20 milligram per deciliter. So we all know that this is not a clinical decision value. It is just the lower limit of the reference interval established long ago. And therefore, we should not take this 0.20 as the magic number. We should know that we should follow the reference lower limit provided by your laboratory, which is affected by different analysis methods, standardization, as well as the age of the subject you are testing. So ceruloplasmin itself is age dependent. It can be very low in neonates. And then it gradually rises in the first few years and then steady until we enter into adulthood. So we cannot apply the 0.20 gram per liter to pediatric patients or women on estrogen or pregnant lady. And we also know that there are limitations on the ceruloplasmin. 10 to 20% of the heterozygous will have low ceruloplasmin, and about up to 30% of Wilson disease on hepatic presentation with acute liver failure, acute inflammation. Because ceruloplasmin is a positive acute phase protein, it can rise up to a normal level. So it may make this marker less useful in these situations. So I tried to collect some insights from different analytical platforms. You can see even within the same instrument, they can have different reference interval, depends on the reagent lot they are using. And also the reference interval varies across different analytical platforms. So in 2008, our group established the diagnostic cutoff value for ceruloplasmin against ATP7B genotyped subjects. So we have 57 Wilson disease patients and their family members. 49 are heterozygous, 22 are homozygous wild types, and then we also have another 25 subjects clinically suspected for Wilson disease with about 700 normal subjects, and they are genotyped on the ATP7B to confirm that they are truly the case. So we have these 5 groups. We can see the reference interval group is all about this 0.14, but there are lots of them fall below the 0.2 level. And for Wilson disease patients, most of them fall below the 0.14, and heterozygous is above that. Homozygous wild type is also above that. And validation group, there are 2 fall in this 0.14. And you can appreciate that this level performs better than the conventional value of 0.2. So the sensitivity can up to 93%, and specificity is 100% compared to the conventional one. In breaking down the data, as you can see, if we are using 0.20, we will have 60 false positive case that is saying that it's low ceruloplasmin and you need unnecessary investigations. But if we are using 0.14, there is no false positive, and there are 4 false negative. But these patients, you have a urine other clinical pictures, like they present with liver problem, they have KF rings, or they have high urine copper level as well. So from the whole, as a whole, you will not miss these 4 subjects in our study. So we proposed each locality should establish their own cutoff for Wilson disease patients instead of just using the conventional one. Or the second best is to follow your laboratory reports, the lower reference interval. So liver copper, some in the past believe that this is a golden test, but in our experience, it is not, because when it is only indicate when you have inconclusive cases. But most of the time, those patients are in acute liver failure and they have a coagulopathy problems, they have bleeding tendency. So it is not really wise to do an invasive procedure at that moment. And because of the heterogeneous distribution of the copper in the liver, most of the result comes back to be inconclusive region as well. So even the guidelines nowadays still recommend liver biopsy, but in our laboratory, we can provide a genetic diagnosis within 1 or 2 days. So I would believe that nowadays, the technology development, the laboratory should be able to provide you an urgent request on genetic tests for Wilson disease. So the last diagnostic challenge is using of the scoring system. I don't know how's your own experience on using this set of data, but they have the symptoms covering CNS problem, hemolytic anemia, laboratory tests on copper, liver copper, and the stains or plasma mutation analysis. I think unless you have a very extensive workup on your patients, you should involve all, or your patient present full-blown to you. Otherwise, in patients with just hepatic or 1 or 2 symptoms presentations, you do not have enough score or you do not have enough confidence to use this scoring system to classify them whether they are more likely or probably or unlikely. So I was still looking forward for a newborn screening in Wilson disease, as well as a more readily available genetic test that can cater for the clinical need with a rapid turnaround time. That would be the best way for diagnosing Wilson disease. So as I mentioned that unless the patient have all marker parameters being assessed before you use this score system, or the patient present with full-blown presentations, otherwise, they will usually score low. So for the genetic diagnosis, we know that there is not a large gene, just 21 exons. Now they shouldn't be a problem. The mutations are very heterogeneous, up to 500, and before or now, because it's a smaller gene, using next generation sequencing seems too much. And so Sanger sequencing is not so difficult nowadays. One day should be able to finish all the analytical work. So it's extraction, Sanger sequencing, and then you can just read the mutations. It's a very well-studied gene, and the variants are very well-studied. So the probability of finding various unknown variants is much lower in probability. So in East Asian, we have these founder mutations, and in Caucasian, they have another one. So it's quite ethnic specific for the genotype spectrum. And in Japan, Taiwan, Hong Kong, in China, all the Wilson disease genotypes have been thoroughly studied. So we all share quite common mutation spectrum, especially this R778L. So it's on the top of the 3 mutation spectrums in Asians. The diagnostic yield of genetic tests among Wilson disease patients is also high, up to 100% specificity and 98% sensitivity. So it's the most decisive diagnostic tool. And these are the genotypes that I will give you. And in the past, we may have to use a haplotype with the family tree analysis. So the mutations, most of them will be splicing, missense, and insertions. And so if for our experience, we will propose that if there are typical presentations of the KF ring, liver derangement, CNS problem with a low plasmin that can enough to diagnose Wilson disease, we can go ahead. But still, we still need family screening by genetic testing especially those asymptomatic siblings. So if we are Southern Chinese or Japanese, our mutation are more similar. We can start with the common exons first. If there is no mutation, we can screen for the rest. But because now it is so readily available in genetic tests, we just go ahead for all the exons. And so for still in the guidelines in 2008 and 2012, they suggest liver copper biopsy, but if your laboratory can provide urgent tests for you, so most of us will skip the liver biopsy and go ahead to the genetic testing. Same as in 2012. So I will recommend if your laboratory can provide your urgent test, that will be much better for the diagnosis of Wilson disease. And that I will skip this one. So I would like to share with you 2 cases on Wilson disease more interesting. One is this one we published in Lancet before. So this is a 30-year-old gentleman, chronic Hep B, and we refer to that. So it's positive in antigens, the ALT is high, same as the viral load. So on the treatment, he was starting on this antiviral management. And so the titer go back to normalized later. However, his ALT still remain 160. So it's rarely to have a, usually it's one man, one disease, but when 2 common disorders come together, there's still a chance that he has an underlying second condition. So in view of his persistent ALT elevation, so they look for secondary causes and finally found that her ceruloplasmin is actually normal. But the urine copper is high, really high. So they consider a Wilson disease could be a possibility. And the patient did not have a CNS problem, then he has no cavering as well. So just a very suspicious high level of urine copper. If you're using a score, he might not be able to diagnose as Wilson. So you need a genetic testing, and we found a compound heterozygous mutations for him. So when put on penicillamine, his ALT normalized, and we have to also screen his family for Wilson disease if he has any siblings. So this is another family that there was a kid. Actually, this lady was this girl was 6 years old when she was first diagnosed with Wilson disease. And she has a brother, 11-year-old. At that time, we screened with the ceruloplasmin. This one was a little bit lower than 0.20, but he was managed as a normal. And so you can see if this is a 11-year-old boy, he still falls within the age-specific reference interval with his 0.16 ceruloplasmin level. But you can also appreciate that when a children's reference interval is aged across a year, 1 month to 1 year old, that reference interval is not so reliable. You can tell that because the partition of the age is so broad, it's not feeling into the normal physiology in changes of serum ceruloplasmin. That also tells you this reference interval is not so reliable. And therefore, even if forced into a normal range, if at that time it's still available, one should go for genetic testing. But we come back to this family. We just picked him up at the time he was 18 years old, and we found the same mutations as his sister. At that time, he had hand trauma and liver impairment as well. So if you have any case being tested before with the less optimal biochemical markers, you may consider revisit the case with the genetic test. So, I have said how good the genetic test is, but sometimes it can also have pitfalls. Like this is a girl with 9 years old, abdominal distension, lower limb edema, significant liver derangement, cavering is positive. So biochemically, you can see it is undetectable ceruloplasmin, very high urine copper. So this is a bingo, a Wilson disease subject's diagnosis. So they refer to us for mutation analysis. The parents are heterozygous, one of a frame-shift mutation with a missense, long sense. However, for the lady, we just find a normal. We have found 3 mutations here, so it should be 3, but we insert 1 more 8. So this is very strange. Why there will be a homozygous insertion together with a long sense mutation, but the father do not have this insertion. So this is a diagnostic problem of the genetic test, what we call allele dropout So in PCR, we know that there will be a primer, a new link to the DNA sequence. So when the primer, there was a SNPs, the primer cannot annul here, where the normal wild type W is the wild type strand cannot be amplified. So only the mutant be amplified, and that's the result. You see a homozygous mutation there. On the other hand, if the SNP present to be the wild type or the mutant type, you cannot. You will miss the amplification of the mutant allele, but just amplified the homozygous wild type, and this will cause you a false normal result. So we redesign the primers, and then we pick up the same heterozygous frame shift of the subjects. So in summary, you can appreciate that sometimes the lab may just screen the exons by tier. So they screen the common mutations first. If they find 2 mutations are homozygous or common heterozygous, they will stop. So there is a chance that will be an allele dropout leading to a false diagnosis. And it will be especially a problem if you use that false genetic data to do family screening. So my recommendations nowadays is more easier to do the whole exons, all exon sequencing before you interpret the data. And we have always to combine clinical data, biochemical data, and family history with the genetic results together. So I will switch a bit on iron overload. That's my second last part of the presentations. So we can appreciate iron overload. There will be the hereditary hemochromatosis, which are the commonest one among Caucasian. But since in Chinese or Asians, we have different mutations involved rather than HFE. And so if for HFE related, usually are autosomal dominant and adult onset, they have the liver cirrhosis or the cardiomyopathy problems are associated with HCC as well. And for the common type in Caucasian HFE is autosomal recessive type, adult onset, moderate. There are childhood severe type, recessive in the HJV or this hepacin, and also autosomal dominant one if the ferroportin. So some will use serum transferrin saturation and ferritin as a screening. If it's normal ferritin, normal saturation, no further investigation. But if shows a biochemical picture of iron overload, we can do HFE. And if it's confirmed 2 founder mutations, then you can, depends on the ferritin level for the treatment. But this is more for Caucasian iron overload cases. For I will skip this one as well. So for long Caucasian population, we may have to think of long HFE-related genes. So, but in the past, there are known to be rare, but I think this is a more understudied group that we can further develop on it. So I have to skip it because in the past we have screened our Hong Kong population and found that there's none of them carrying this C281 mutation, and thought that Hong Kong has no HFE. I think similar findings are in other Asian groups as well. But we encountered another case that is another mutation that is not HFE. So this is an adult 43 years old with a high ALT, white upper quadrant discomfort, and there's no risk factor iron deficiency, iron overload, and not Wilson disease as well. But biochemically, you can see this is an iron overload pattern. MRI liver is also with iron depositions. So we screen it negative, but as you know that this is an adult and the condition is moderate, so we start on this gene, ferroportin, and we found 2 mutations as well. So this is the first case of the ferroportin deficiency in Hong Kong populations. So up to this 2019, more of the technique is NGS. So we can either use exome analysis for you have undetermined etiology liver failure. And this paper, they use a whole exome analysis, 3 patients. You can see that this 10-year-old female actually diagnosed with Wilson disease using the scoring system. She has a high urine copper, low ceruloplasmin, and KF range. But undetectable ATP7B mutations, very interesting. So with the exome, she actually has a mitochondrial depletion syndrome. And the second baby is also a mitochondrial problem with encephalopathy, Leigh syndrome-like conditions. So another one is this one is a syndromic cholestasis. And they found this is a notch 2, which the Alagille syndrome like conditions. So you can see that hepatology in pediatrics or even in adult, they can be very mimicking or disguised. So I think NGS with a panel of monogenic conditions do really helps in some difficult cases. So I look forward to more data and experience sharing in application of NGS in this field. Thank you very much.
Thank you very much. So could you please receive some questions now?
Yes.
Not in this panel discussion. Okay.
Okay. Oh.
So, is there any questions and comments? Please stay on the stage. No questions? Okay. So you show the newborn application of newborn screening and diagnosis challenges, including serum ceruloplasmin, hepatic coma kappa contents, and genetic test. But we often see the patient with Wilson disease having already developed cirrhosis. Because I think because Wilson disease patient exhibiting extrahepatic manifestations. So it is I often think it is difficult to make an early diagnosis. So how about the Hong Kong situation? Different from Japan? So early diagnosis is very easy or very difficult?
I think the experience should be quite similar. Depends on the experience of the hepatologist or the neurologist or the patient see. And there are some papers studying that the most difficult diagnostic marker is the clinical suspicion. If the clinical suspicion is low, one will never pick that up, and the delay in diagnosis actually in terms of years, it can be in terms of years, even to the psychiatrist. Yeah, so it is difficult. Our patient in my study, about 50 subjects of them, delay in diagnosis in terms of years, a few years. So that's why newborn screening is the way to pick them up for timely treatment. Yeah, because once you diagnose, when they have established all those damage, the drug is not so effective. There still be a lot of damage on them. Yeah.
May I?
Yes.
Oh, yes.
Yes.
I'm Dr. Omata.
Yes.
I'm not a pediatrician, but my hospitals can get dry spots, blood dry spots, 6,000 every year. Because I'm in the county. The county name is Kofu. And it was said that all the newborn babies dry spot came to my hospital, 6,000 a year.
Yes.
So for the last 5 years, we have collected almost 30,000 dry spots. Then to make use for the molecular diagnosis, just 2 weeks ago, we picked those one, even the 3 years old dry spots, and we extracted DNAs. Yes. It was almost several hundred nanograms, which can be done for any genetic diagnosis. So actually, we are planning to make the whole diagnostic procedures, because nowadays there are 800 genetic disorders can be diagnosed by molecular basis. So if we have money, if we have funding, and if we have dry spots, you can cover whole things.
Yes.
So that's the kind of things we have to do. Hong Kong, China, Taiwan, and Japan.
Yeah, I look forward to this. Thank you, Professor. Yeah, the problem is just the money problem. Yeah, it's expensive, it's not so affordable. Yeah, I look forward to that.
In addition, not just the money, but this is a genetic disorders. So you got to get very careful attention about the families, and then you got to get the right informed consent to do that.
Yeah. Yeah, I think compared to other genetic conditions, Wilson's is the best one because the mutations are most well studied among it. So the chance of making vowels uninterpretable variants are less likely.
But unfortunately, I have not encountered a single case since I came back from the United States for the last 40 years. So maybe I'm missing, hetero cases. But in reality, for the hepatologists in Japan, we don't have much chance to see the patients. But as you point out, there might be the kind of the occult or, subclinical cases. Yes.
Yes. Okay, thank you. Thank you.
Do you have any comment, Professor Need, about the newborn screening about Wilson disease? Yeah. Okay. Here. Do you have any comments? Okay. Thank you. The panel discussion. Thank you.